I'm an internist, general internist. I've been an independent solo practice for 15 years, and prior to that, 4.5 years with, I think, the same factory clinic. It's a big one. Begins with an A. Back in the 90s, the state put in MinCare, which was really a form of Clinton care, and pretty much destroyed independent general internal medicine practice across where most of it was concentrated here in the Twin Cities. And prior to that, I was in 15 years of small group practice, which is kind of the norm for big cities. And I had a choice to do rural care, but quickly chose not. That's a really tough environment for an internist, whether you're solo, definitely, but also with even in groups of family docs. It's got its own unique challenges. I should. Sorry, Bob. In the last 15 years, I was considered crazy and nutty as well. I still am. Just ask the boss, otherwise known as my wife. She gave me permission to flee from the big clinic, and I chose to go into third party as I restarted practice again, which was a rather unique thing to do for an internist in the midst of a big city. Actually, it hadn't really happened since the 50s and 60s, and it was unique to Minnesota's destruction of private practice 5 years earlier. So I needed a banker with a sense of humor, and I needed equity. Otherwise, it was nearly impossible. And I started an office, did third-party payment, and from 2003, 1999 to 2003, it was working okay. I knew how to run an efficient office. I had 2 employees. And, but 2003 to 2011, with continued non-fix SGR fixes, basically our fees went down 30 to 50% net against our cost of doing business. So by 2011, I was practically paying to see every Medicare patient I saw as I calculated it out. So I had the key chat with the boss again, and she gave me a 2-year opt-out option, which complied with the federal option. And it's a big step, even within the realm of a big city, particularly when you're about the only thing like that, although there have been a few other physicians who have done it. Not too many on the East Metro. I'm from St. Paul. I'm one of the 9,539 of 2012. I opted out January 1st, 2012. And then throughout 2012, I decontracted from most of the major carriers that exist here. There aren't too many that exist actually in Minnesota due to the way the law is. There's really only 4 main carriers that distribute non-Medicare work. They're all conforming and cutting down to Medicare levels anyhow. So I think we've always had as a single pricer system. We're as close as we're ever going to get to a single payer, because neither Democrat or Republican are ever going to get away with getting rid of Blue Cross United Health Group. And I think Zeke Emanuel said that practically a month or so ago, that his form of single payer will include them as the administrators, which is hardly helping anything out. I'm in favor of what I've done as being a physician again, working directly for the patient. And I think it's getting back to something I really haven't. I haven't really lived until I've done this, and I feel the most like a physician than I've ever felt. As I looked at the pricing or how to do that, certainly I looked at a concierge style. There's a large one that comes through most states, MD VIP out of Florida, and very successful. And I didn't like the idea of being a high value only internist. But I had always prided myself on having a demographic that is rather broad. And one of my goals in choosing how to price my fees was to maintain that. So my overriding philosophy was to have concierge care at non-concierge prices as my guiding philosophy. And And in doing that, I do have some packages, as Dr. Reese had highlighted, that some of us have done. I bundle certain packages for people who have frequent visits that are predictable, Coumadin patients, diabetic patients, and for an upfront fee, they get a big discount for the whole year, and I just take care of them. The other thing that's happened in the last 10 years, not only here, but almost across America in the big cities, general internists are either inpatient or outpatient only. It's almost impossible to control and take care of inpatients and outpatients at the same time. And practically since 2010, I was, or actually since about 2007, I was paying to see every inpatient patient if you look at the time value of what you're doing and how many calls you get per day per patient. Plus, there are no other internists left in the Twin Cities that are independent, practically, and certainly not in the East Metro that I could do call with. My on-call partner has finally given up in the last 2 years and now works for one of the big clinics again. I'm 24/7 with my patients. I do give them my cell phone number. It's a different style of practice. I've had these patients in my practice since 1980. And with the big shift in my practice and talking to all the patients, I'd talked to them for really more than the last 2 years about this. They saw my frustration. One thing about patients is they read the EOBs. Doctors don't. EOBs are the estimation of benefits. They know what's happening. And frequently through the last 20 years, I had patients presenting me with checks for the difference. They'd give me a check for $500 and say, Dr. Gehrig, I see how they're just cheating you. I want you to have this. And of course I give it right back, thinking there may be an FBI plant or something. Said, no, this is a felony. You take that back. And thank you, but give it to charity or something, but don't use my name, you know. I get it, and they get it. As I've always said, they know what to do between the flea market and the Mercedes dealership. That's their everyday life. Patients know how to do this and how to discover price and value about almost everything. And what I do in the office is not dissimilar than any other, going to a lawyer, accountant, or any other business, really. Getting back to that has been rewarding for me. And to look at what's happened with the practice, probably 40% of the patients left. Any internal medicine practice in the big cities is roughly about 60% Medicare, as I see it in the several big cities that I know about. And it's certainly that way for my practice. And of my current practice, I would say 60–65% of them are still Medicare patients. So they obviously have to opt out with me, sign the affidavit every 2 years. I got my new affidavit renewed January 1st. They didn't tell me that the carrier left the state. And it took me a week to find out that our carrier now is in Indianapolis, National Government Services. And they're all electronic, so I had to daily, if not 3 times a day, ensure that they got my 20-digit number that ensures that they received my request to opt out again. And within 10 days, they were quicker than the local one. The first time, I hand carried it to the office, which was locked down, and I had to knock on the door, and I took a picture of the person taking my affidavit, because the physician who had done that before me failed to get the affidavit approval, and he needed the United States Senator 6 months later, and after $20,000 worth of legal fees, to finally get it approved that he was indeed opted out. Otherwise, he would have had to go through really a career-ending, if not business-ending enterprise. As you do anything with direct pay, I think one of the most important elements is keeping your costs low and even dropping your cost. As I say, aim small, miss small, and I think what I'm really about is the art of small. I can only see one patient at a time. The clinic she and I worked for was 11,000 square miles of coverage, which is what, 1.5 times the size of Massachusetts, with 25,000 employees, 3,500 physicians. And it has nothing to do with patient care. I think patient care is 80 square feet. having the time to sit and mostly listen to the patient. Figure out, that's how we were all trained, by the way. And the perverse nature of third-party payment and the constriction and restriction of our fees just leads to higher volumes and less time with patients. And the application, I think the inappropriate application of electronics has left even less time with that patient, has been highlighted several times already. So costs and keeping them down. I had 2 full-time equivalent employees, a lab person, front desk, a billing person, when I started in solo practice. And now 2.5 years later, I'm down to 0.4 full-time equivalent in adjusting to the flow of cash and what it costs and what I need to do to maintain the business. For me, thriving in this big city of giants is surviving, and I'm doing that. That's my goal. And the boss is mostly happy about that. She's a Democrat. Speaking of Democrats, July 30th, 1965 is where some of the major modern problems began happening. The first Medicare patient signing in there is Harry S. Truman, who wanted national health insurance back in 1949 but didn't get it. Our Vice President Hubert Humphrey's in the background there, and I think Wilbur Mills is behind Bess Truman. He had to be coerced, and I think LBJ had the stripper pictures already by then, if anybody remembers the history of that. But that started our, I guess, again, perverse ways of doing patient care in America. We go up 45 years later, and this is the modern plan of Obamacare. Nice and simple. Great outline. And as I approach healthcare and have for many years, and thinking about what I need to do, I was on CIRMO, which I'm on a lot. It's a national physician chat room. It's the doctor's lounge that no longer exists in our local communities. And I like it because it's colleagues sharing all kinds of conversation about healthcare and even patient care. 2 months ago, a Boston pediatrician put what I think is one of the best diagrams for the style of healthcare that we should get back to and that anybody can understand. And it's this. Patient and doctor, and occasionally the insurance comes into play for major catastrophes. This is the easy focus. It's what we do with car and homeowners insurance, and the catastrophes are about as frequent and is about the same size. And all folks know how to do that. Insurance companies actually know how to do it. They just have a better deal in terms of managing care as well. There's talk often on CIRMO of we need to get unionized and basically add a fourth party. And I'm so against the idea of 3 parties, much less the fourth party. The third party is fairly thoroughly deprofessionalized. I'm not certain there is a profession left in the country except for those who are willing to step out and actually directly work for patients. Because under contract, you're really not working for the patient in any way other than your ethical core that is so hard to deliver in 5 or 6 minutes. So I'm sensing what we all need to do and what we all have control over is each doctor has a license and it affects thousands of patients. That should be our common bond. We can unionize over that thought, and you don't need more than each doctor willing to do that. I was encouraged when I heard David say that large urologic group is thinking about going to direct pay. That's the level that needs to be done. There aren't enough internists left to make a difference. We're pretty much gone. I don't see it coming back. You only have to look at the last 20 years of production out of medical schools. Medical students have walked, and they can't afford to go into general internal medicine. They just can't, not to the percentage kind to replace us. And it's really for the surgeon specialists who are now being indentured and enslaved like they did cardiology 3 years ago across the land. They turned them down 20, 30% in their key fees 2 years in a row and took them out of business. And they'll have to do that to all the other specialists because they're running out of money. Patients are living easily into their 80s and 90s, particularly in the major cities where most of the money is being spent. And the Ponzi mess of Medicare that LBJ started in July 1965 works extremely well if you're all willing to die at 71, which was the actuarial promise of 1965. And of course, that's not what the politicians have been willing to adjust to since the 1980s, when that's been clear that it's not working out. Our effort at doing what we can control, each doc and each license, is about where we are, and I would encourage anybody to consider it as well. It's not easy. I don't sleep as well, but it's not about worrying about, it's about, are the patients actually coming, you know? They get it. They're primed to get it. Everything else in their life is like this. And I've never had anybody question the price or say that's way expensive. In fact, I think my prices are too low in many cases, and I'm always discounting. I'm not like a lawyer who charges when I ask for about the kids. I want to know about their kids. I like the personal attention that means. I can remember them better, but I get that I have a lot of power. It's a very asymmetrical situation, and I get my responsibility. And I ultimately sign death certificates, and I get that. And I've got patients that have been with me 34 years now. And I have patients that my two partners who hired me 34 years ago, I have a plaque in my office dedicated when I went to solo practice to these gentlemen. I have patients from the 1950s that they saw. Patients get it. We just have to show it to them. So, thank you very much.